Good evening, everyone, and a very warm welcome to this session on neurosonography for the premature infant webinar. It's an online webinar. We from the Thrissur IRIA City Chapter is proud to host this program. The program is twofold. One is from the clinical perspective of a neonatologist and from the imaging perspective of the radiologist. The clinical perspectives will be highlighted by Dr. Manoj V.C. Dr. Manoj V.C. Is a neonatology chief HOD in Jubilee Mission Medical College and Research Center. He is a very well-known figure in the field of neonatology in India as well as worldwide. He has also traveled all over the world. He has published various papers in various national and international journals. He is also the neonatology forums in Kerala and India, and also he is a neonatology chapter IAP executive member South Zone. He is also a good friend, and he is also a proficient in Zumba dancing and is responsible for the fitness initiative in Thrissur. Dr. Roy George is an old friend of mine. Many of you might be remembering from Thrissur Medical College when we did our DNB together. He is currently the head of Department of Radiology and Imaging Sciences at Oasis Hospital, Al Ain, UAE. He has done his FRCR and MEd Radiology from the National University, Singapore. He is also versed in cardiac MRI, fetal echo, and all those things, and he's the right person because he's working currently in the Women and Child Center of the Al Ain Hospital. Welcome to you, Dr. Roy, and Dr. Manoj will be joining soon. Before we start the session,
I joined that.
So. Dr. Manoj has joined. Thank you.
Sorry for the late entry.
It's okay. Thank you, Dr. Manoj. We welcome you. So without much ado, there is a short presentation by Mindray. I would like to thank company for providing this forum. So we have given them time for a short presentation. Over to you. I'll stop sharing.
Thank you, Dr. Rajesh. Good evening, doctors. My name is Ekambram. I am from the Product Marketing Department within Ultrasound Division in Mindray. Very warm welcome to all of you. And we would also like to thank the IRIA Thrissur for this partnership opportunity. I'm sure many of you are aware our recent lecture we arranged with IRIA on a national basis on the latest advances of shear wave elastography, and we also launched Resona I9 Premium Ultrasound during that program on the last Sunday, 18th of July. And both these shear wave lectures were been very highly appreciated, and very similar to this, we also support education programs across the imaging of all the specialities. And so we are very, very happy to be part of today's, cranial sonography, which is one of the interesting part of Mindray Ultrasound program. And for almost 2 decades, Mindray is a rapidly growing brand in healthcare area, and Mindray Ultrasound is no exception. Thanks to the close relationship of Mindray, we are developing every day with all our customers. And this is purely based on innovation, which again, based on the deep insights that we have from users like you, and also the pain point that you go through every day. And we have been launching many innovative products covering radiology, OB-GYN, vascular, MSK, cardiology, and so forth. And fortunately, based on our initiative of innovation and the customer insights and also the ergonomics, very highly appreciated from our design point. For our product that we launched in 2021, we have received the most prestigious Red Dot Design Award as well as IFO Design Award for the best design of ultrasound system for 2021. And Mindray's new general imaging premium ultrasound system, Resona i9, that we launched recently, brings a lot of innovation and agility in the premium segment. And most importantly, Resona i9 brings a new generation of acquisition and processing technology called zone sonography technology, which is almost 10 times faster as compared to any other currently, prevailing ultrasound technology by any manufacturers. And about this system and also many of the important features, we will now share two product videos, one on the technology side, one on the clinical side, but it's a very short video. So we are very, very happy once again to be part of this program. So we are on behalf of Mindray team, let me thank Thrissur IRIA team, as well as all of you who have joined today for a great program ahead. We will now share the program. Video, sorry.
Sir, we cannot hear the sound.
Yeah, right.
Can you pause the video, please? We are not able to hear the sound.
Okay.
So Nikhil or Manoj, somebody can do something about this.
Yeah, Nikhil, you please share.
Yeah, just a minute.
Please, Nikhil is trying to do something about this, sharing the video. is the first part of the video, and we have a short video for another couple of minutes on the clinical side of this. Nikhil, can you share it again?
I'm going to show you the advanced features and performance of the Retina i9 system. I'll start by scanning the abdomen using the SC61 transducer. We can see the smooth and uniform liver and detailed renal image from near to far field. The i9 enhances the resolution and penetration, specifically for liver diagnosis of difficult patients, using sound speed compensation. This is a system that adapts sound speed to enable optimal tissue-specific imaging. Now, I'm going to show you the new glazing flow imaging. This is a brand new, innovative way to demonstrate the color and power Doppler flow in a 3D visualization. It provides an intuitive and easy visualization of renal flow, especially very tiny vessels. The i9 provides shear wave technology for scanning the liver. It has sound touch elastography, STE, which enables the precise quantification of liver stiffness. This helps to grade the diagnosis and prognosis of liver fibrosis and cirrhosis with a good level of reproducibility. Thanks to the powerful processing capability of the ZST Plus platform, the new sound touch elastography provides the highest frame rate of shear wave in the field, up to 10 times faster than the previous frame rate. This provides results with better stability and higher accuracy, giving you more confidence in your clinical diagnosis. The Retina i9 has quality indicators to improve the accuracy of measurements in shear wave images. The best possible frame for the STE image is indicated by 5 green stars in the Motion Stability Index and a completely green reliability (RLB) map. This shows good shear wave quality and the presence of reliable indicators for better reproducibility of the stiffness measurement. Smart HRI is available on the Retina i9 system. It automatically calculates the brightness of the liver with the renal cortex in B mode. This Smart Hepatorenal Index auto measurement is a fast, simple, reliable, and cost-effective screening tool for identifying patients who do not have to undergo a liver biopsy for evaluation of steatosis. Now, I'm going to show you thyroid imaging with the L14-3, the new linear transducer in the i9 system. We can see a good uniformity of image throughout the thyroid parenchyma. I have now added the glazing flow, which demonstrates the blood flow using 3D visualization. It helps to intuitively understand the structure of blood flow and small vessels. Let's now move on to breast imaging with the L14-3 transducer. This breast preset maximizes the image quality, enhancing the contrast resolution to separate information about the lesion from the breast tissue. Activating the HD scope shows the lesion with higher resolution imaging in the ROI box. As you can see, the HD scope improves the image contrast in the specific area. This is especially useful for displaying the boundary and inner structure of the lesion. Smart Breast automatically calculates the mass contours and presents all the standard ultrasound features. It has demonstrated great potential in cancer diagnosis. As you can see, the i9 system provides standard protocol guidance on the touchscreen for high efficiency. It detects and measures the lesion automatically, then displays the result alongside the report. Smart breast or thyroid tools will make your routine clinical ultrasounds more accurate, productive, and easy to complete.
Doctor, that's a brief insight about our Resona I9, which is a general imaging system, and it's creating really huge waves across the Europe. And thank you for this opportunity, and wish you once
Thank you.
program.
Thank you, Mr.
Thank you,
Ekambram.
doctors. Thank you, sir.
Now, without much ado, we'll start the program. I invite Dr. Manoj V.C. I had already introduced him. He was also to say he was my senior in Thrissur Medical College, and he was the chairman of our college union. To add to that, and he is also involved in the health activities of doctors in Thrissur. Proponent of Zumba dancing. Then, apart from so many academic things, he already is in the field of neonatology. Over to you, Dr. V.C. Manoj. He will give us an insight to what we made this topic as seek and speak. What we should look for, and what language we should be speaking, and that is very important that we speak in the wavelength, same wavelength as that of the clinician. That is very important. And over to you, Dr. Manoj. Welcome.
Thank you so much, Dr. Rajesh. Now, Rajesh, so kind of you to remember our college days, and also for the kind words of introduction. So without wasting any more time, shall I start? Can I share my screen?
Yeah, sure.
Okay. At the outset, let me thank again Dr. Rajesh and the team behind this very unique event, where it's a multidisciplinary approach to the new way to go to approach any problem as far as clinical medicine is concerned. Good evening, everybody. So today we are going to discuss the various aspects of neonatal brain ultrasound, the cranial ultrasound, or whatever you want to call it. So let me just go back to our good old days when we were medical students, and we were told that there are four pillars to bedside examination: inspection, palpation, percussion, and auscultation. But now, increasingly, there is a felt need to add the fifth pillar, the insonation. Why this has come? Because now the cranial ultrasound is the ultrasound as it is coming from the sophisticated machines that we have in your office to the bedside. So this change is probably what is getting reflected in neonatology as well. So in modern day neonatology, the fifth pillar of examination is, we call it otherwise a POCUS, point of care ultrasound, where we, during each day round, if possible, the idea would be to look at the brain, look at the heart, look at the lungs, look at the gut line, look at the lines. So these are the basic 5 things we always should look at. But now POCUS is expanding more and more, so we keep talking about looking at the kidney and things like that. But the idea is that the one-time examination or one-time imaging is not good enough in a neonate who is adapting from the fetal environment to the postnatal environment. So how is the adaptation going wrong? Had the adaptation been going right, then those babies would not have been in neonatal ICU. They would have been with the mother, and we don't do all these tests on them. So the very fact that you're going to test on them, which means that something may be wrong with the natural postnatal adaptation that the nature would have wanted. And this is where the role of ultrasound comes in. Now, I would focus my talk today exclusively on brain. We will not, probably these days people talk more about brain and heart have been the established concepts in POCUS for now more than 2 decades. But now lungs, gut, and then the lines and all other things are coming. But we will anyway restrict our talk only to the brain. So as far as brain is concerned, what is POCUS or the cranial ultrasound going to tell us? It's going to tell us, as far as what do a clinician want, he has some focus questions. Is this baby having intraventricular hemorrhage? So these focus questions are asked every day by the bedside. Has he developed? Because it's not a one-time affair. Once you diagnose and that is it. It's not like adult medicine. We all know that neonates are in the bridge between both the worlds. So it's a dynamic evolution that you need to analyze. Secondly, having picked up a lesion like an IVH, you need to monitor that. And how is it? Is it going bad or is it improving? So for both, POCUS is the ideal way. The serial monitoring, of course, heart, if you want to do the hemodynamics, is the one that you look at. But in brain also, the hemodynamics do need to be looked at. So why do you need POCUS or cranial ultrasound by the bedside? Of course, bedside technique means the baby need not be shifted every day to the out of the NICU, which is a cumbersome process and sometimes just not possible in a baby when on ventilated with inotropic support and etc. etc. It's readily accessible for defining any brain injury we have, and it's not a one-time affair. Of course, provided the person who does it has time, we can do a real-time follow-up of the evolution whenever you want it. Suppose you find a clinical deterioration, put the probe and see what is going wrong. And in the sickest, as I said, in the sickest and high-risk preterm infants, probably it may not be a good idea to move them to the lab to do the detailed ultrasound. And of course, the decision making also sometimes, like the typical example is in intraventricular hemorrhage or in functional echocardiography, we say the PDA, whether it is whether you need to start the closure, medical closure, when can you stop, and things like that. So it's a functional decision for clinical management. So now, in addition to this, we have the second part, that is the detailed ultrasound. So before you go into that, why do you need a detailed ultrasound? Well, detailed ultrasound is definitely required. It's just a bedside ultrasound alone might not be enough, but that is the most practical thing in the sickest baby. And when the baby is fit, definitely we need to look at all the aspects. We know now that cranial ultrasound is superior to MRI in identifying some of the lesions, calcification, lenticrostriate vasculopathies, germinolithic cysts and all. And especially in diseases like CMV infection. Now CMV infection is getting more and more rampant, and these days we are seeing more and more newer manifestation. Probably because the prevalence of the higher prevalence of CMV infection in the mothers in the current era. And idea is you can't do MRI is a costly evaluation. You can't do MRI every day. CT scan is out of question. So then probably you are only left with ultrasound, and a detailed ultrasound cannot replace a bedside ultrasound or POCUS, but both have their own place. And secondly, the machines that we use for bedside ultrasound, the Doppler examination, should be these days now. You are the better judges. This is an august forum of people who are actually doing it, so probably you would know better. The machine, the previous era, we did not have machines that did an accurate ultrasound examination of the blood flow velocity by the bedside. But now probably the differentiation is being blurred. The better machines are coming and they're being utilized in the bedside. And now we know that detailed evaluation and a serial evaluation of brain growth in the preterm baby can help us in the prediction of neurodermal outcome. MRI giving you a structural one-time view may be inferior to the repeated serial ultrasounds in a good hand. When do you do this? I know the next speaker is going to talk on when and how. I would just draw your attention to the recent guidelines last year by the American Academy of Pediatrics, which compared the various neuroimaging of preterm infants. Cranial ultrasound should be done routinely in all neonates, sick neonates. And one of the new changes is that now not only anterior frontal, the mastoid frontal also has to be routinely evaluated in cranial ultrasound. Of course, the posterior frontal, the temporal windows and vascular images are optional depending on when you need or not. initial scan, now the timing, actually there is a lot of variation between the American protocol, Canadian protocol, UK protocol, the India we have a NNF protocol and all. There's a lot of variation. So the 2020 AAP guideline says that the initial scan should be done within the first 7 days of life, the repeat scan at 4 to 6 weeks, and then at term, because these are preterm babies you're talking about, at term of 40 weeks you should be doing. However, in our NNF guidelines, we added one more parameter, because in the first 3 days we get the incidence of IVH and all is much more. So probably one more scan is added in the first 3 days, and second one between 7 to 10 days, and third one for 28 days, and fourth one at term. So depending on the protocol you can do, and probably the next speaker is going to tell us more about the recent guidelines on and how each one of is going to be useful for us. Cranial ultrasound is not the only imaging. MRI, AAP does not really recommend it as a routine this thing, even though bodies like the Canadian and various other bodies do recommend it to be routinely done at least once. And ideally MRI should be a non-sedated MRI. But this whether to do it or not is based on which protocol you are following. And all the protocols are very vehement about the radiation exposure in a growing brain, and then CT should be avoided in and it should be the last resort when nothing else works. And the windows, as I said, now the mastoid frontal, because now we have started seeing more and more cerebellar hemorrhages also. That's why probably this has come in the new guidelines. Now a little bit about the clinical perspectives. Now when I ask for a cranial ultrasound, or when I do a cranial ultrasound, depending on the clinician or person who is doing it, what is it that you want to find out? You are actually trying to look at the evolution of the various diseases, the brain injury, or the markers or consequences of various diseases on the brain. So the brain injury, the commonest is the intraventricular hemorrhage, especially in the preterm babies. 15 to 20% of babies below 32 weeks have been reported to have IVH. That's a very large figure if you look at the numbers. And then the hydrocephalus, which may come along with that as or part of the anomalies. And then of course the preterm infants, especially with the problems in the mother like chorioamnitis and things like that, you now have the periventricular leukomalacia coming in a big way. And then of course in the not only in the preterm baby, the meningitis, and now we started using respiratory index and things like that for hypoxic ischemic encephalopathy. Birth asphyxia babies you can serially monitor, and in conditions like seizures, anomalies everywhere. So cranial ultrasound do have a role in any brain injury, you name it, there is a role. When you have non-brain injury but babies have get stuck on ventilator, baby have comorbidities, in such scenarios like in cardiac failure or a hemodynamically significant PDA or in sepsis, probably again cranial ultrasound has a role. We'll just briefly, this is in seek and speak, so I will just look at what I am seeking and then let us discuss on that. IVH, we know the original classification by Papal is CT scan based, where you have grade 1, 2, 3 and 4. For this August audience, I am not going to elaborate on this classification. But can we go beyond this classification, beyond the Papal classification for IVH? Yes, we have now started doing, and we have Professor Volpe's classification of evolving classification of intraventricular hemorrhage. That is based on purely based on ultrasound, where you have 3 grades, grade 1, 2, 3, and then you have a separate group of periventricular hemorrhagic infarction. So now grade 1 we all know. Now, so any baby can evolve through this. That is the beauty of this arrangement. Like it depends on what day of life we are doing the cranial ultrasound. The other ways you are just going to do once a time. CT scan you are going to do more than one. You don't do CT scan now, is it? So if you are going to do, you are going to do only once. So you are really not going to do justice. Whereas in ultrasound, you can keep going on. Every day you can see if you have time. At least the days when, we, as per the recommendations, as per the unit protocol, when you look at, you can see whether what is the evolution of the bleed. Initially, we know because of the typical anatomical features, the germinal matrix is the area that, and especially in the chordothalamic notch is the area where it starts bleeding. So that is where you find, and that is a grade 1. And once the blood spreads on to the lateral ventricles, till the time it is up to 50%, we call it grade 2. When it fills more than 50% of the ventricle, we start calling it grade 3. So it's a very easy classification, but with lot of prognostic significance. And when it's beyond that, when the hemorrhage has spread into outside the ventricle, and what is going to happen is there are a lot of venous connections, and these veins are going to get infarcted, and this is the tragic periventricular hemorrhagic infarction, a short for brain injury in the subsequent days. So why do you need this classification? This will tell us much better. Previously we had only this, so where you tell us 0% grade 1 is dangerous, only 5% dangerous, 20 to 55%, 80%. But this is a very static, rigid way of classifying a brain lesion. And if I am the parent, I would like to know more than this. So grade 1 and 2 previously, which we thought will all resolve and then they're okay, we now know that they may not become okay. There are enough studies now which tell us that they may initially appear to be okay, but there may be possible adverse effects depending on the studies. I can name it, the severity is even up to frightening levels, but the outcome through the school age, scholastic performance, everything has been reported to be less than optimal in these grades. Where of course, but the major problem of course definitely comes in grade 3 and beyond. So in grade 3, the mortality itself has been reported as something like 10 to 20%, and cognitive and motor deficit is very, very high, 30 to 40%. And when you have more than grade 3, when you have periventricular hemorrhagic infarction, in these cases, yes, the mortality is pretty high, 50 to 80% mortality, and neurologic impairment is also pretty high. But having said that, now the beauty of cranial ultrasound focus is that we know beyond this. Now we know that it is just because you brand it as PVHI, and appendicular hemorrhagic infarction, doesn't mean it's so bad. Depending on the site of the lesion, if it is in the parietal lobe, it is pretty bad, because that is the area where you know that all the important things, connections all take place. So these babies are likely to develop contralateral cerebral palsy. Whereas in the frontal and temporal lobes, outcomes have been varying and it's not as bad. So real-time prognostication and the gradation. So it tells us much more data regarding the interventricular hemorrhage, and this is the beauty of ultrasound. And then so after doing an ultrasound, when you counsel the parents, because you need to correlate with the clinical profile, and this is where this really helps. Now, as I said, the new concept that is gaining the importance is the bad adverse outcomes with cerebellar hemorrhage, and cerebellar hemorrhage has been noticed, especially in the even in the term babies in asphyxia and things like that. So it is now recommended that all cranial ultrasound views should also report a mastoid view. Basically, the idea is to look at the cerebellar lesions and of course the other things. But then of course, if you have enough time and things like that, you should look at the other windows also. Not only the anterior frontal and mastoid window, posterior frontal temporal window, and various other areas also you can probably look at. Now, one of the dreaded complications of interventricular hemorrhage is the hydrocephalus, and then hydrocephalus, when it happens post-hemorrhagic, there is always a confusion of what to do. Now, cranial ultrasound comes very, very handy. So you look at 3 indices. The Levins, I don't need to tell you what is that, because you are the people who does it every day. You need to look at, so as far as the neonatologist is concerned, he needs to know what is the Levin index value, what is the thalamo-occipital distance, what is the anterior horn width. And having got all these values, what am I going to do? I am going to prognosticate. I will see, okay, now when the ventricular index or any of these values is 4 millimeters above the 97th centile. So 97th centile is based on the charts available. We have no charts for various population and various things. So and there is the action line is 4 millimeter above. So you have a 97th centile values, and then when it's 4 millimeters above that, that is the time you call the neurosurgeon, request him for a shunt or some sort of intervention, because this is the recommended time when you do intervene. So here the values to remember are probably, I don't need to tell you these values, all these values are known to you, so I'll skip this. Another problem, since we started now seeing smaller and smaller babies, is the periventricular leukomalacia. And this is a lesion that is a very interesting lesion. Some of the babies, see these babies whom we subsequently detect to have spastic diplegia and all, these babies actually, you know, if you trace the history, they don't have much of NICU history. They just, preterm baby, born at 28 weeks, received some CPAP, and then baby was well, baby started tolerating feed, shifted to mother, discharge and all that, and then routine ultrasound, or rather during the hospital stays that you do, and then you find periventricular leukomalacia. So, which means that this is a lesion that is defying the logic, and when we started looking more into it, we now know that the antenatal factors like the chorionitis all have some role to play in this. The grades of PVL, I'm not going to tell you again, this is not, you are the people who should be talking extensively, and then we are going to have a session on this, grade 2, 1, 2, 3. And then of course the grade 4. But let me just look at what the neonatologist want. So I need to first know that what is the grade of PVL that you are looking at. So this is again for those who are actually interpreting, actually probably this mistake still keeps happening. The grade 1 PVL you report only after 7 days. Before 7 days, all the periventricular echo densities that you see in a preterm can be reported as normal. After 7 days only you term it as grade 1. And then as it evolves into small localized cysts, you call it grade 2, and then you extensively grade 3, 4. Unfortunately, cranial ultrasound is not good for non-cystic PVL demarcation, where probably MRI scores, but then cystic PVL is a common one, and that is what we'll discuss. So, to predict the outcome, we now know that later ultrasound is more useful. Serial ultrasound is always better, so we'll know that how fast is that progression from the previous value. And then if you look at the figures, by the largest cohort of extreme preterm babies from the 2019 published in Neonatology by Bartones et al., then you find that 83% of grade 2 PVL and 91% of grade 3 PVL have risk for cerebral palsy. So this is as far as cystic PVL is concerned. The diffuse non-cystic white matter injury is an area of grave concern these days, but then you can know it is there, but the grading and reliable prognostication is probably not within the scope of the ultrasound. We also now have various other, we need to know that, so basically when you have a baby, a high-risk infant, preterm or a high-risk term baby, the question parents are going to ask is, how is the brain going to be? Is the baby going to do well? Is the baby going to achieve the milestones on time? Is the baby going to do well in school? So prediction of neurodevelopmental outcome, now we have recently incorporated various new parameters like a corpus callosum length, circumference area. Previously even there is a time when you say absent corpus callosum, oh, there is nothing. But we know now that all has their own significance in their perspective. Biparietal diameter, ventricular ratio, ventricular size, subarachnoid space enlargement, all these may help us in predicting the neurodevelopmental outcome. So ultrasound is a whole package. It is going to give us a wealth of information, and inspection, palpation, percussion and insonation has to be the way when you examine a neonate. The last little bit about the cerebral Doppler and the resistive index, I'll just touch only on this because this is again the clinical implications are too many. So why am I interested in the resistive index? Because babies who are depressed at birth, asphyxia. So if I can calculate the resistive index, and then you have a golden value called 0.75 and then plus or minus 1, if you're going to take that as value. So when you have a lower resistive index and a progressively lower values, then you are probably looking at worse outcome. And in various other conditions like hydrocephalus, PDA, sepsis, etc., when the RI may be high or absent, or even there may be reversal. So all these are going to tell me some information about the progress of the baby. So I think we will stop here and discuss further, since I have overshot the time. Let me again thank Rajesh for this great opportunity to interact with you. I am ready to take questions. Thank you.
Thank you, Dr. Manoj. That was exactly what we had asked for. Your presentation was excellent.
Thank you.
I think we will take the questions later and invite Dr. Roy and have the discussion after. We'll have a panel discussion after this, if that is okay with you. Manoj, is it okay?
Yeah, perfectly okay. I'm interested to hear what Dr.
Yeah.
Roy want to. It's a learning process always.
Yeah.
Thank you.
So, Dr. Roy George, you may not met him. He is currently working in UAE Al-Ain Hospital. I had already introduced him in the before the talk. Yeah, he has worked for a short stint in Thrissur Medical College when Dr. Ratnakumari was the chief here. The DNB from here along with me. Over to you, Dr. Roy. He will give us the how. Now, Dr. Manoj has described what is expected from our part, and Dr. Roy will focus on how it is done and what is to be done, what points we should be looking for. Over to you, Dr. Roy. Dr. Roy, you are muted. You are muted still. Muted. Yeah. No, you're still muted now. You're again muted yourself. Okay.
Okay. Are you able to hear me?
Yeah.
Okay. First, let me start sharing
Share
my
it.
screen. I'm not able to. Now I'm not able to share my screen. Are you able to see my screen?
No. Nobody is sharing screen now. You should be able to. Can you see the share screen button? Are you able to see the sharing button?
Yeah. But when I'm okay. Now I think it's coming.
Yeah.
Are you able to see?
Yeah. You can make it full screen now.
Yeah. So I hope everybody can see the screen. You are able to see the screen?
Yes, very much.
Okay.
You can carry on. Start.
Okay. Thank you, Dr. Rajesh, for the introduction and also for the invitation to give me a chance to talk to you. And today I will be talking on screening ultrasound for preterm neonatal babies. My talk will be limited only to the screening ultrasound of the preterm babies, because cranial ultrasound is a big topic that we can talk for one day. It includes a lot of elements, but I will be limiting my talk only to the screening ultrasound for the preterm babies only. Preterm baby screening ultrasound is necessary to identify intraventricular hemorrhage. That's the purpose of screening ultrasound of preterm babies. We have a role of ultrasound in neonates, not only for intracranial hemorrhage, but for different purposes. So I will not be including any of that parameters in my talk. So I will be basically trying to convey to you few points that why there should be a screening ultrasound for the preterm babies, and when you should do a screening ultrasound, and how to follow up these babies, and how to grade the hemorrhage, how to look for periventricular PVL. This will be the subject of my talk. So, as an overview, why ultrasound is used? Ultrasound is the most widely used neuroimaging procedure because it's very easy and it can be repeated. And it assesses the neurological status of the child, where clinical and examination and symptoms are often non-specific. The aims of this ultrasound is to, I'm not going to dictate all the details of what I have written here, but our talk will be limited to screening ultrasound. That when we are talking about the advantages, we can start two advantages we should remember very clearly. We can start early imaging and serial imaging. This is the importance of ultrasound screening, unlike CT or MR. Regarding indications, as I mentioned, there are a lot of indications for a cranial ultrasound, but the indication for a screening ultrasound, whether the baby is premature, what is the age of the baby, what is the weight of the baby. These are the criteria to assess the indications. Precautions. We know all the precautions what we should take for ultrasound imaging. But remember, we are dealing with very premature babies. They are in the incubators. So we should do the ultrasound without disturbing the baby, and we should do only in the incubator. As much as possible, don't try to take out the baby and try to maintain the temperature. Avoid unnecessary pressure on the anterior fontanella. Make all aseptic precautions as necessary. The technique of the ultrasound, basically the most recommended probe for a ultrasound is small footprint sector probe. But in my experience, you can use any probe what is available in your institution. But if you are purchasing a probe dedicated for the neonatal brain imaging, it should be for a small footprint sector probe. When we started our ultrasound, we were using a transvaginal probe. Then we shifted to a convex probe. All these probes can give you results, but the optimum results will be given by a small footprint sector. If your institution is capable of purchasing a dedicated machine and dedicated probe, this should be the probe. But all probe has its own advantages. Then linear probe, high frequency linear probe also can be tried if it is available and you don't have a small footprint sector probe. And curvilinear probes. See, whatever probes you are using, it should be able to have 5 to 10 megapixel hertz capability. And all this have its own advantages. Transvaginal probe, if you have, this will give a good images. The only problem is managing the ultrasound in the incubator with a transvaginal probe will be difficult. So these are about some of the probes. Otherwise, whatever probe you have, go on trying it. Try to see the images. You should be able to see the side-to-side brain aspect, and you should be able to see anterior to posteriorly. This is the only concept. And the importance is, you remember, you are doing the scan within the incubator, This will make you restricted in your mobility. So transvaginal probes and all should not be used in a regular basis. But if you do not have a probe dedicated for the brain, you can use any probe which is available with your experience. So when you are doing a scan, we all are doing cranial ultrasound from our post-graduation time. But I don't think we had a dedicated structural or programmed way of performing an ultrasound. So when we are doing an ultrasound for neonatal brain, we should have some protocols. So the standard protocol for brain ultrasound will have 6 coronal views and 5 sagittal views. The 6 coronal views are called C1, C2, C3, C4, and C5. And C6, these are the standard coronal views for performing a neonatal ultrasound. So the C1 is the anterior most scan. You will be keeping the probe in the anterior fontanelle, and you will be moving it slightly anterior, and the section will pass through only the frontal lobe without including the lateral ventricle. So this is the first section that you should be taking, that also called C1, that will pass through the frontal lobes. C2 will pass through the most frontal horn of the lateral ventricle. You will be seeing frontal horns of the lateral ventricle and the rest of the brain. That is C2. C3, you will be crossing, again, will be moving 15 degrees posteriorly. Then you will be able to see the section through the foramen of Monroe. That is C3. C4 will be the mid lateral ventricle through the body of the lateral ventricle. That will be C4. C5 will be through the trigone of the lateral ventricle, where you will see the bulk of the choroid plexus. C6 will be through the occipital lobes, parieto-occipital lobes, and you will not see any lateral ventricle. So C1 and C6 will not have any lateral ventricle. All other views, C2 to C5 will have a lateral ventricle, and I have already mentioned and which level you should be taking. So these are the standard coronal views that you should be doing for all the babies. The importance of this protocol, when somebody analyzes, even if a technician does the scan, in our institution, most of the scans are done by the technicians, or we are only interpreting, like the European countries or other Australia. But I know that in India we are doing it ourselves. But the structured protocol image is important for when you are repeating the scan. You can repeat the scan in the same level, and you can reassess. If you are doing in a slightly different angle, you will not be able to compare the previous image with the current image. Coming to the sagittal images. Sagittal images are 5. The central image is S3. The most right one will be S1. The second will be S2. The third will be the mid-sagittal. Then 4, 5. 1, 2, 3, 4, 5. S1, S2, S3, S4, S5. So we will be starting the scan from right to left, or you can start from the midline to the right, then to the left. So the first scan will be S3. That will be the mid-sagittal brain. You will be able to see the corpus callosum, and that is a mid-sagittal image. Then 2 parasagittal images, that will be 2 and 4. S2, S4. This will be parasagittal images, and these are the most crucial images that you should be documenting to document or show the physician where if there is a chorothalamic hemorrhage. This is the caudate nucleus, and this is the thalamus. This is the chorothalamic groove that should be normal, and this is the choroid plexus, lateral ventricle. And this is the most important image when you are dealing with intracranial hemorrhage. When you are dealing with the neonate, premature neonate, most important sections are S2 and S4. They are called parasagittal images. Then coming S1 or S5, that is going through the insula or the Sylvian fissures. So you will not see the ventricles, you will be see the Sylvian fissure and the extreme parasagittal images. This is S1 and S5. So the coronal views, we can use the posterior fossa as an acoustic window whenever necessary. Usually with a good anterior frontal eye, you will be able to image the whole brain with the available images. But sometimes if posterior frontal eye is slightly bigger or open, still you can use that, especially for imaging the posterior fossa. So now we'll come to the point. So today we will be talking about preterm babies, cranial ultrasound screening for intraventricular hemorrhage. Intraventricular hemorrhage is germinal matrix hemorrhage. So we should know what is germinal matrix. This is a friable tissue of blood vessels. It's a very hypervascular. It's an endothelial lining that normally present. This is the stem source for neuroblast that disappears as the fetus grows in utero. Initially, they line the entire ventricle, and they regress to the chorothalamic groove by 24 weeks. Greatly reduced by 34 weeks and involutes completely by 40 weeks. By 40 weeks of age, you will not see a germinal matrix. That's why there is no germinal matrix hemorrhage in a well-grown baby of 40 weeks or 38 weeks or 36 weeks. You will not see normally a germinal matrix hemorrhage because there is no germinal matrix hemorrhage by that time. The germinal matrix matures by 34 weeks of gestation, so that hemorrhage becomes very unlikely after this age. That is the importance of screening the premature babies by cranial ultrasound. When they are premature, they have remaining germinal matrix and they are prone for hemorrhage when there is a stress on the brain. Germinal matrix is not usually visualized by ultrasound. If you see any echogenic material in the chorothalamic groove, this should be considered as a possible bleed. Cerebral blood flow increases in response to hypertension, hypoxia, hypercapnia, or acidosis. So thereby, they place stress on this vascular structure and causes hemorrhage. The bulk of the choroid plexus is in the trigone or atria of the lateral ventricle. So this is very important. Remember, choroid plexus is present only in the trigone and atria. Also, choroid plexus can be found in the roof of third and fourth ventricle, but not in the floor. And also temporal horns of the lateral ventricle, in the roof, there can be some amount of choroid plexus. There should not be any echogenic material in the frontal or occipital horns or dependent portion of temporal horn, third ventricle or fourth ventricle. This is a clue point that you should remember. If you see any echogenic material in the floor of third ventricle, floor of fourth ventricle, frontal horn, occipital horn, or floor of temporal horns, you should be suspecting hemorrhage. Any echogenic material in the wrong place, I already mentioned these are the wrong places. If you see any echogenic material, this is what is called hemorrhage. The most important point or location where you should look when you are screening for a germinal matrix is a chorothalamic groove. This is choroid nucleus, thalamus. Chorothalamic groove is the place where you will be looking for the germinal matrix hemorrhage. And which is this image? This is a S3 or S5 parasagittal images. This is a crucial image. So germinal matrix can affect a newborn of all gestation ages, but most common in premature. Most germinal matrix hemorrhage occur in the first week of life and often is clinically silent. That is the most important. That's why we are doing screening. If it is an adult, they will present with a clinical sign or symptom. Baby cannot speak to you. The neonatologist may not be able to identify the neurological sign. That is where we, the radiologist, should do a screening ultrasound for this neonates. Germinal matrix hemorrhage is reliably diagnosed with ultrasound. Yes, ultrasound is the investigation to diagnose germinal matrix hemorrhage. Parenchymal injuries, ischemia, petechial hemorrhages, hemorrhagic infarct can be diagnosed with ultrasound, but with less sensitivity. Routine screening for germinal matrix hemorrhage is performed in infants of less than 32 weeks or less than 1,500 grams. So these are the crucial points that you should remember. Based on this, we select when we should do a screening ultrasound. All this is based on the timing of intraventricular hemorrhage. All the babies less than 32 weeks, out of them, 15% will have a germinal matrix hemorrhage. Less than 32 weeks, 2.9% of them will have grade 3 or 4 hemorrhage. If they are more premature and they are less than 28 weeks, then 15.5% of them will have grade 3 or 4 hemorrhage. The more premature the baby, the more chance of having a hemorrhage and more chance of having a higher grade of hemorrhage. These are the 2 points that we should keep in mind. Then let us look when the hemorrhage occurs. 50% of the hemorrhage occurs within 24 hours. Another 25% occurs in the next day, within 48 hours. Another 15% occurs in another 24 hours. So 90% of the hemorrhage occurs within 3 days or 72 hours. So this is a point we should remember. This will decide in a screening protocol when you should do the first scan. So this all will be based on this thing. If you do the first scan in 24 hours, you are missing the rest of the 40%. If you are doing a scan in the second day, you are missing then another 15%. So ideally, there are protocols when you should do the scan for the screening for the first time. There are different protocols designed by American team, British team, and every country has their own protocols. But American protocol says you should do the screening ultrasound for all babies less than 32 weeks. And screening should be performed at 7 to 14 days and repeated at 36 to 40 weeks. British team says if the baby is less than 30 weeks, they should do one scan at day 1, day 3 and day 7 and day 28 for the evaluation of periventricular lucency. And babies, if it is 32 weeks, day 1, day 7 and day 28 for the PVL. In our hospital, what we follow is basically based on American Academy protocol. We do a day 3 when child is asymptomatic, anytime if a patient is symptomatic, and follow based on the first scan, and day 28 and time corrected scan to evaluate for periventricular lucency. So I don't think every hospital is following any defined protocol. It based on their experiences. The basic understanding that we should have is 90% of the bleeding occurs within 3 days. So you can have a primary scan after 3 days. But if you are delaying, if the baby is asymptomatic, there is no harm in delaying until 7 days, so that you may get until up to 100% of the bleeding in that primary scan. So it depends upon the scan set by the head of neonatology at that hospital in discussion with the team. So the primary understanding that we should have is every day when you are progressing, there is an increased chance of finding a hemorrhage is increasing up to 7 days. But the follow-up scan should be done day 28 or at the time of discharge, it should be time corrected. That is for identifying periventricular leukomalacia. Follow-up scan is based on the primary scan. But remember, scan can be done on the first day or any time if the child is symptomatic. What I am talking is only about screening ultrasound for intraventricular hemorrhage. At the time of the birth, if the baby has a convulsion, you should do an ultrasound immediately. You should not wait for a screening ultrasound. So now we'll come to the grading of germinal matrix hemorrhage. The popular classification that all of us know. There is no much controversy on this. Grade 1, grade 2, grade 3, grade 4. Grade 1 is a simple hemorrhage in the germinal matrix and it is not extending to the ventricle. Grade 2, it extends to the ventricle but occupies less than 50% of the volume of the ventricle. Grade 3, it extends to the ventricle and ventricle is dilated and it occupies more than 50% of the lateral ventricle frontal horn. Grade 4 is a parenchymal hemorrhage with or without grade 1, 2, 3. That is the classification. Previously, we all had a wrong concept. At least I had a wrong concept in my post-graduation days that grade 4 hemorrhage is an extension of this germinal matrix hemorrhage into the parenchyma. But this is proven to be not the same situation. The situation is something like this. Grade 4 hemorrhage can occur without a intraventricular hemorrhage or germinal matrix hemorrhage. Grade 4 means the baby has a venous infarction in the parenchyma. The venous infarction could be due to compression on the exiting the veins due to a mass effect due to any cause. Most commonly with the intraventricular hemorrhage causing obstruction of the outflowing veins causing venous infarction. So coming to grade 1, you have a small germinal matrix hemorrhage, that is grade 1 without ventricular dilatation. Grade 2, there is an extension to the lateral ventricle, but lateral ventricle is not dilated and this is not occupying more than 50%. Grade 3, the intraventricular hemorrhage extends, the germinal matrix hemorrhage extends to the ventricle and it is occupying more than 50% of the ventricle and the ventricle is dilated. That is grade 3. Grade 4, it is unrelated. There is an area of hemorrhagic infarction in the brain. This baby already had a grade 2 hemorrhage. The third day scan, it extended and caused hemorrhage in the parenchyma. But remember, hemorrhagic infarction in the brain can occur without any intraventricular hemorrhage or primary germinal matrix hemorrhage. The sequelae of intraventricular hemorrhage, one of the chief concerns with the grade 4 bleed is the loss of brain tissue resulting from degeneration of the necrotic area. These venous infections resolve with cyst formation, resulting into a porencephalic cyst. This is the most worst situation. This intraventricular hemorrhage can cause necrosis and porencephalic cyst formation of the brain. Regardless of the cause, the neonate with the grade 4 bleed is at very high risk for adverse neurological outcome. Cerebellar hemorrhages. I think Dr. Rajesh already mentioned about cerebellar images. We are also seeing a lot of cerebellar images, especially for the pregnant ladies when you are giving high dose of aspirin in IUGR cases. And this aspirin doses, I think it's affecting the babies as well, and they are prone for more hemorrhages. Not only cerebellar, without germinal matrix hemorrhage, we are seeing babies with parenchymal hemorrhages in patients who are treated with aspirin in their pregnancy. The prognosis of intracranial hemorrhage, the grade 1 and grade 2, these are clinical aspects. Actually, Dr. Rajesh has already mentioned, but just I will go through what I have prepared. The grade 1 and grade 2 generally have a good prognosis. Outcome in grade 3 hemorrhage is usually good when no parenchymal injury was occurred. Generally, bad prognosis for grade 4, as expected. And what can happen when there is a intraventricular hemorrhage? They can have post-hemorrhagic hydrocephalus. periventricular leukomalacia, seizures, cerebral palsy, mental retardation. These are the usual sequelae that we see and follow up. Coming to periventricular leukomalacia, this is also called hypoxic ischemic encephalopathy of the preterm. This is an alternate name for periventricular leukomalacia. It affects the periventricular zones, resulting in cavitation and periventricular cyst formation. Why this occurs? This is a watershed zone. We in adults we describe watershed in fact. So where there is two territories meet, they are the watershed zones that will be affected when there is a stress. So in premature, this white matter zone is the watershed zone between the deep and superficial vessels. So they are the areas which are affected when these babies are put on stress due to any cause. So periventricular leukomalacia occurs most commonly in premature infants. And out of if they are less than 33 weeks, almost 38% of babies will have periventricular leukomalacia. If they are less than 1,500 grams, these are from the two studies, almost 45% of them will have leukomalacia. Detection of periventricular leukomalacia is important because a significant percentage of surviving premature infants develop cerebral palsy, intellectual impairment, and visual disturbances. So how you diagnose periventricular leukomalacia by ultrasound? Early periventricular leukomalacia presents as an area of increased periventricular echogenicity. And this echogenicity should be more than that of choroid plexus. The most significant sequelae of periventricular leukomalacia is cystic change of the affected brain matter, which can develop as late as 4 weeks after birth. This is very important. Ultrasound findings may be normal in the primary scan, but they develop clinical and delayed imaging, which will show periventricular leukomalacia. Ultrasound is highly reliable in detection of cystic white matter injury, that cystic periventricular leukomalacia, grade 2 or more. But they have limitations in identifying non-cystic periventricular leukomalacia. I think Dr. Rajesh has already mentioned, see, part of my talk was already taken care of by Dr. Rajesh, so I am not dealing with that. So non-cystic white matter injury is considerably more common than cystic white matter injury. So 2% of the preterm neonate born before 32 weeks develop cystic periventricular leukomalacia. How to grade periventricular leukomalacia? Grade 1. They will have just increased periventricular echogenicity persisting more than 7 days. This is a very difficult situation, and any scan you do, you will think there is a periventricular echogenicity and should not be confused for this thing. And you should do a follow-up scan after 7 days. If it is persisting, you can call us periventricular leukomalacia. Otherwise, it is a flaring. Grade 2, development of small periventricular cyst. Grade 3, development of extensive periventricular cyst in the occipital and fronto-occipital lobes. Grade 4, development of extensive subcortical cyst. This is a grade 1 periventricular leukomalacia. But this is a very controversial area that many the beginners are likely to keep a diagnosis of periventricular leukomalacia for most of the patients. If there are areas of increased periventricular echogenicity without any cyst formation persisting for more than 7 days, that is called grade 1. As I said, it is non-specific finding that must be differentiated from the normal periventricular halo or normal hyperechoic blush posterior superior to the ventricular trigons. These are the normal things that should not be confused. And suspect periventricular leukomalacia if the echogenicity is asymmetric. See, they will not be symmetric in both sides. And their course, they are not homogeneous. They are globular or more hyperechoic than choroid plexus. So just if you see a hyperechogenicity which is less echogenic than the choroid plexus, don't label them as grade 1 periventricular leukomalacia unless they are inhomogeneous, asymmetric, coarse, or globular. Grade 2, development of small periventricular cyst in the frontoparietal lobes. The echogenicity may be resolved at the time of cyst formation. So the initial echogenicity, what you have seen, might have resolved when you see cyst. Cystic periventricular leukomalacia identified on the first day of life indicate that the adverse event was at least 2 weeks prenatal rather than perinatal or postnatal. I hope you understand this point. If you see periventricular cyst in the first day of scan, it means the baby had an insult at least 2 weeks before. So this is not a problem of the perinatal or postnatal. It was a prenatal issue. So this is a grade 3 extensive periventricular cyst in the occipital and frontoparietal region. And grade 4 periventricular echogenicity in the deep white matter developing into extensive subcortical cyst. Periventricular grade 4 is seen mostly in full-term neonates. And 1 to 3 is a disease of the preterm neonates. This is another point that we should remember. Grade 4 periventricular leukomalacia may be seen in full-term neonates, but grade 1 to 3 is a disease of the preterm neonates. Flaring, as I mentioned, if you see a periventricular echogenicity that disappears in 7 days, that is called flaring. It has no clinical significance. Periventricular leukomalacia, there are a lot of differential diagnoses. You may see the similar appearance in other ischemias, bacterial infections, periventricular hemorrhagic infections, infections in cells, malformations, genetic and metabolic causes that we are not discussing now. Periventricular leukomalacia, the limitations of ultrasound. Ultrasound has limited sensitivity and specificity in detecting periventricular leukomalacia, especially if the lesions are very small and grade 1. Grade 2, 3, 4, there are no problems. Ultrasound is highly sensitive. But in grade 1, ultrasound has limitations and MRI may be able to help. Serial ultrasound examination and the use of brain MRI can improve this detection of grade 1 PVL. MRI is the imaging modality of choice for diffuse non-cystic periventricular leukomalacia. With the increasing survival rate of extremely preterm infants, the non-cystic form of periventricular leukomalacia has become important in the current neonatal care of preterm infants. We know in our learning time, babies born out 30 weeks or 32 weeks or 34 weeks never used to survive. Now we are able to give life to babies even for 24 weeks, 26 weeks. So this is the importance or advancements in the neonatal care. So which has increased the premature babies surviving, which has increased the number of premature babies developing intracranial hemorrhage. And so the number of intracranial hemorrhage has increased because of the surviving babies number has increased. Coming to the prognosis, I think Dr. Rajesh has already discussed these points. So babies born 28 to 32 weeks, the classical type of periventricular leukomalacia with cyst formation, it is related to the development of cerebral palsy. 28 to 32 weeks, they most usually goes for cerebral palsy. Less than 28 weeks, diffuse cerebral white matter injury. Their neurologic outcome is predominated by cognitive impairment, and they are less likely to manifest the typical spastic diplegia, cerebral palsy syndrome at school age. Less than 1,500 grams. These all are studies which are shown these findings, and Dr. Rajesh may be able to describe more as I am not a clinician. They are particularly prone to brain injury that involves periventricular leukomalacia associated with neurological axonal disease termed as encephalopathy of the prematurity. Common sequelae includes cognitive, behavioral, attentional, and socialization deficits, while cerebral palsy, major motor deficits, is a less frequent outcome in the more premature babies. So when we are discussing about periventricular leukomalacia, you should be familiar with the very common cystic lesions that you see in the brain when you are screening in the brain. So they can be classified as a gliosis, or either the baby has gliosis or hemorrhage. If there is a gliosis hemorrhage, there can be seen whether it is above the lateral ventricle, periventricular leukomalacia. If it is below lateral ventricle, there may be subependymal cyst. And there is no gliosis or hemorrhage, there can be conatal cyst. This is a graphical representation I have made. This is a periventricular leukomalacia. There will be above the ventricle. This is a conatal cyst that is also called a coarctation of the lateral ventricle. This is a subependymal cyst. This is a porencephalic cyst. That is very clear. But these all cystic lesions should be differentiated from periventricular leukomalacia. Coming to conatal cyst, this is very commonly seen, and this is a congenital anomaly that is also called a coarctation of the lateral ventricle, and they are seen in 7% in low birth weight babies. This have no significance, and they result from the approximation of the walls of the frontal horns, and they form coarctation, and they will appear as a cyst. Actually, this is a continuation of the frontal horn by a septum. So this is a conatal cyst. That should not be confused for periventricular leukomalacia. Subependymal cyst. There can be two types, either acquired or congenital. Acquired ones are sequelae of the small hemorrhage. They form a cyst formation. And congenital ones are germinolating cyst. They are just inferior to the frontal horns and posterior to the foramen of Monroe. But conatal cyst is anterior to the foramen Monroe. These are the two differentiating points for the radiologist. And here comes the periventricular leukomalacia. They will be superior to the frontal horns and in the parenchyma. So this is a correct location of the periventricular leukomalacia cyst. Porencephalic cysts are sequelae of damage to the brain, necrosis, and formation of cysts. So they are the most commonly formed after a hemorrhagic infection, or you will see a necrosis. Then you will see they are communicating with the lateral ventricle. They are porencephalic cysts. That's a appearance that you will see. They all should not be. That's very easy. It should not be confused for periventricular leukomalacia. In conclusion, all preterm babies should be screened for germinal matrix hemorrhage and periventricular leukomalacia. Ultrasound is the most widely used neuroimaging tool in premature infants because we can repeat any time, any hour, any day, whenever you want, and it's very easy to handle. And appropriate protocol of imaging and timing should be followed. This will be based on the departmental decision. And the only thing that we should remember is the slight delay in the primary scan will improve the detection of the hemorrhages without unnecessary follow-ups. Special care should be taken for the baby in the incubator. That's very important. We are dealing with the premature babies and we should take care of their safety. And MRI imaging modality of choice for diffuse non-cystic periventricular leukomalacia. Thank you. And that's here the end of my talk. Hello.
Thank you, Dr. Roy. That was an excellent presentation. It was very systematic, going from basics, technique, what to look for, and how to go about it. Only issue I had was you referred to Dr. Manoj as Dr. Rajesh many times.
Oh, sorry.
Okay. Okay. Before taking questions, one issue I thought was that Dr. Manoj had mentioned about another classification system of the hemorrhage. So are there now two systems classification?
Can I answer?
Yeah, Dr. Manoj, please.
Yeah, so actually Professor Volpe's classification is actually, the basics are still the Papay's classification only. What is actually being the dynamicity is given to that classification. If you say grade 1, 2, 3, 4, and basically the original Papayal classification is based on just CT scan. You don't do CT scan on a neonate anymore. So the classification is invalid. Whatever here described are based on the CT scan findings. So now it has been modified subsequently. So the Volpe's classification is purely ultrasound based. So probably that is a more, and it has a dynamicity to it. That is why probably the grade 4, which was there in the papiles can be thought of as gray, the periventricular hemorrhagic infarction. But then, as rightly said by Dr. Roy George, this can occur even without an intraventricular hemorrhage. So these aspects are better explained in Professor Volpe's classification. So I think it's time to, it's not very new, it is also quite old, but much after 10-15 years after the Papay's class. It's time to go on to the Volpe's classification, because that is what actually we are not using CT scan to classify anymore. Is that okay explanation?
Yeah, Dr. Roy, would you like to add?
Actually, I'm not familiar with this classification. I have not heard. First time I'm hearing from Dr. Manoj, and we are not following this classification. So I will read more on that, and I will see how it can be
actually, this is
in my hospital. Yeah.
Actually, that is the point. While we should have across the consult, we are basically, you should understand that we are doing it for the clinician, and but they should also understand we are doing it for the baby. So what should be best for the baby, that should be done. So if there is some disparity in what we are conveying and what the clinician we should be, I think we should, if there is a change required, we should go for that.
That is exactly the point. Actually, most of the time there is a disconnect between the person who actually does and the person who actually asks for. That is actually not going to serve the purpose, because so that probably, as you said, this dialogue is very, very important.
Yeah, it's thank you, Dr. Manoj and Dr. Roy, for the inputs. Are there any questions? One question is maybe it's Dr. Roy. Any experience with the elastography to prognosticate a neurodevelopmental outcome? Has elastography got any role?
Actually, I have no experience.
Oh, okay.
Can I just make a few points regarding elastography?
Yeah.
See, elastography is one of the recent techniques to increase the diagnostic capability of the classical ultrasound. The problem in ultrasound is we always say it's subjective. This has added an objectivity to it. Actually, what is happening is the tissue. Originally, elastography came as an ultrasound tool in liver, but then now it has been extended to other areas like the brain also. And now recently, from France originally and from other countries, there are various papers which are looked at the neonatal and cranial ultrasound elastography, looking at how it adds to the sensitivity and specificity for various neuropathology. Actually, what is actually elastography? It is actually detecting the tissue stiffness between various areas. So so if you can quantify this ultrasound, the problem everybody says subjective. So it is not subjective anymore. If you can really put in this elastography concept, it is no longer a subjective thing. You are actually going to measure the values of stiffness. So it has the potential. I'm not saying that is the standard of care. It is not. But it has the potential to add some objective and quantitative data to the ultrasound imaging. And actually, in neonatal brain, why this is important is, it is like liver. It's always liver in an adult also is it's never the same. It will keep growing and all the thing. Here also the myelination, neuropil formation and all. So what is actually happening is the brain is evolving in the neonate. So the stiffness of the same area, good that I really like the way Dr. Roy George said C1 to C6. If you are going to put it that way, and I wish we had the luxury of our technicians doing the ultrasound and then giving us to interpret it. So if you are going to objectively do that, so here what is actually happening is the brain stiffness in the same point of view, you are going to look at the stiffness and then you are going to interpret whether that is going to predict the lesion, how is it progressing. So potentially it has got a lot of application, lesions like PVL and all that. Elastography can really change the way we define PVL. And so that is there, but the studies are all still studies. It is not the standard of care in neonatal ultrasound. Probably in liver, adult liver, I know that it is the standard of care. The ultrasound elastography can be done for various things, but then not in neonatal ultrasound. People have started doing it in the last 5 years. People have started doing it. Papers have started coming in. People are saying that this may help us to better prognosticate neuropathology. So that is all. I think that's the importance. I don't think we should discuss elastography in the context of cranial ultrasound. Of course, it's a recent advance. I do not want to add these because as it is, we were looking at the practical aspects, isn't it?
Thank you, Dr. Manoj. Actually, the question Dr. Rajesh asked me about my experience in elastography in brain. That's what I said. I don't have any experience. Actually, we are doing elastography for thyroid, breast, and liver.
Yeah, we are.
And we are doing, but I don't have any experience in using for brain. I thought you have some experience.
No, I don't think anybody in the country here in India are doing all these papers are come from the West.
Okay.
The cranial ultrasound elastography papers, original one was from France, and then subsequently we have from various countries, US, Canada, and all the various papers. I don't think anybody, to my knowledge, correct me if I'm wrong, cranial ultrasound elastography is not being done in neonates. Probably under research setting, somebody doing, I'm not aware. Please correct me.
Okay, thank you. Dr. Roy, I know you are confined your topic to neonatal screening. Would you like to add any word on Doppler? Dr. Manoj had mentioned MCA Doppler.
See, the Doppler can be used based on the resistive indexes and vascularity, but this is not done in a screening ultrasound. This is all called diagnostic ultrasound, and even for a congenital anomaly, we do a diagnostic ultrasound. So my talk was based only for the screening ultrasound for germinal matrix hemorrhage, and there is a role for even IUGR babies. We do a cranial ultrasound, and we see the resistive index and how much resistance the brain has. Similar effect we can derive from the postnatal brain ultrasound of the neonate. And we have some cases where we have done, even we were able to detect some vascular anomalies also when we are doing Doppler, but this is not the part of a screening ultrasound of cranial hemorrhage.
Yeah, I know. Thank you. One question was how to differentiate it from infection. I don't know what that specific infection, maybe the leukomalacia.
See, differentiating different infection or anything, it's a subject of discussion. It will have a different clinical aspect. That's not a part of screening ultrasound. See, anything in the periventricular areas, echogenicities, there will be a lot of differential diagnosis. I have listed a number of diseases which can be mimicked by periventricular leukomalacia. This all will go with the clinical settings and in discussion with the neonatologist. We may be able to. They will present with the same patient with meningitis will have a different type of clinical presentation, and that's not what we are expecting with the intraventricular hemorrhage.
I think we have finished questions. Dr. Manoj, do you have anything to add?
I just saw just now I opened a Q&A box. Somebody has written elastography may help to diagnose grade 1 PVL, some studies report. That's what I said. In non-cystic PVL now there is a scope for with the cranial, but these are all study. Do not go by study reports. The basic thing is evidence has to evolve. You cannot say that as you can do elastography, brain elastography, and probably no. The thing is that there are reports, promising reports. Let it evolve. Till then, let it be under the research setting only. It's not a standard of care. And I really want to thank Rajesh and the Radiology Forum for having this interactive session, because this is the way it should go. Most of the time, the communication gap can be really sorted out by such meetings. Actually, congratulations, you have started in a very nice venture. It needs to be encouraged beyond the sea. And thank you so much.
Thank you, Dr. Manoj and Dr. Shafi. Dr. Shafi, Unmute yourself. Okay.
Yeah, it's a well-balanced talk between Roy and Manoj sir. So Manoj sir was elaborating on what clinician needs from our reports. And I would add that we should approach a case like an algorithmic approach, whether it is present, then how you proceed to the next level, like how we should proceed. I mean, after some days we should repeat. That is well elaborated from both of you, and I don't think many will have more questions on regarding this topic, because all are well covered. Thank you so much, sir.
Thank you. Thank you so much.
Thank you very much, Dr. Roy and Dr. Manoj. Good night. And Dr. Shifi, thank you.
Good night. Good night.
Yeah, we'll call it a day.
Bye-bye.
Thank you. Good
Thank
night,
you.
everybody. Thank
Good
you.
night.